Now, let's turn our attention to the dural sinuses. Now, the three layers of the dura that we find here are to some extent the same as what we see in the spinal levels, but there was one significant difference. The pia mater is fundamentally the same. Pia mater is fused to the surface of the brain, just like it is to the spinal cord. Outside of that, we have a subarachnoid space containing CSF. Outside of that, we have arachnoid, just as we do at the spinal level. But outside of that, we have dura mater, which is somewhat different at cranial levels than it is at spinal levels. At spinal levels, there's dura mater, and then outside of that, there's a space called the epidural space, and then we reach the bone. At cranial levels, it's different. We have fundamentally two layers of dura, one of which is fused to the surface of the bone, or at least tightly attached to the surface of the bone, and that's called periosteal dura. And that simply follows the bone wherever it goes on the interior of the cranial cavity. The other layer of dura is called Meningeal Dura, and while the Meningeal Dura in many places is fused with the periosteal dura to form one continuous layer of dura, there are places where those two layers of dura separate from one another, with the periosteal dura following the contour of the skull and the Meningeal Dura following, to some extent, the contour of the brain. And when they separate from one another, they create a space between them that contains venous blood called a dural venous sinus. And illustrated in this section would be the superior sagittal sinus, one of the major dural venous sinuses. And much of the venous drainage from the brain drains into these dural venous sinuses, which eventually, by way of the sigmoid sinus and the inferior petrosal sinus, as we said before, ends up draining into the internal jugular vein. Now, there are three different major categories of intracranial hemorrhage or intracranial bleeds that are associated with these layers of dura. They are different from one another and they arise from different blood vessels. Let's start with the one that we've already made reference to, and that is tears of the middle meningeal artery. Now, that's not shown on this picture because that would be way off to the lateral side here. But recall that the middle meningeal artery is tightly sandwiched between the dura and the bone. And so there's normally no space between the dura and the bone, so there is no normal epidural space like there is at spinal levels. But if there's a tear of a branch of the middle meningeal artery, that blood will seep into that plane and separate the dura from the bone. And that accumulation of blood will now be between the dura and the bone, and we'll call that an epidural hematoma. An epidural hematoma. Secondly, we can see this representative vein here. This is a vein that's coming from the surface of the brain. It's sometimes called the cortical vein because it sort of bridges across the subarachnoid space. It's often called a bridging vein. And it's taking venous drainage from the cortex, going across the subarachnoid space, and then penetrating the arachnoid and dura to drain into this dural venous sinus. Well, this creates an interesting problem for us. As that vein is traversing the dura, because the dura is such a tough fibrous layer, at that point the vein is being held tightly in place by that tough dura. However, where the vein is on the surface of the brain, as the brain moves, the vein moves. And of course, the brain does move a little bit inside the cranial cavity since it's floating in the CSF. So when you get a rapid acceleration or deceleration force, a blow to the head or anything of that sort, as the brain shifts a little bit inside the cranial cavity, that movement of the vein gets stopped at the point where the vein is passing through the dura. And as we've previously discussed when we were talking about the urethra, we said that when a structure passes from its most stable to its least stable region, that's where it tends to tear. And so with those kinds of forces, you'll get a tear of the cortical or bridging vein right at this point, and the blood will seep into the space, again, that doesn't normally exist between the arachnoid and the dura. Normally there is no space there is no subdural space. But if this vein leaks at that point, you'll get blood accumulating between the dura and the arachnoid. We'll call that a subdural hematoma. And then lastly, we see vessels such as shown here or here or here. These are representations of branches of the cerebral arteries or branches of the cerebral vasculature. And those vessels are subject to aneurysms and ruptures of those aneurysms, cerebral or perianeurysms. And if those aneurysms rupture because these veins are in contact with the CSF in the subarachnoid space, if these blood vessels rupture or leak, the blood will leak into the subarachnoid space and mix with the CSF, and that'll be called a subarachnoid hemorrhage. So we have three different categories of intracranial bleeds resulting from three different kinds of vascular accidents. So to summarize that, we said epidural hematomas between the dura and the bone or from ruptures of the middle meningeal artery. Subdural hematomas between the dura and the arachnoid are from ruptures of the bridging cortical veins, and subarachnoid hemorrhages are from ruptures of the cerebral arteries into the CSF. Here we can see radiologic images, one of an epidural hematoma and the other of a subdural hematoma. Because of the tight adhesion of the dura to the bone, the blood that's in an epidural hematoma tends to stay in a more restricted area, causing the hematoma to expand more from side to side, resulting in this fairly characteristic lenticular appearance to an epidural hematoma. And you can sort of get the sense that this blood is not able to seep very far in that direction or that direction because of the tight adherence of the dura to the bone. In contrast, if we look on this side, we see how the blood was able to spread quite a long distance, sort of following the contour of the brain. This is a subdural hematoma where the blood is spreading between the dura and the arachnoid. Because we don't have anything adhering into the bone, we're able to get this much greater extensive spreading of the blood, and it tends to assume this more crescent-shaped arrangement, more or less following the contour of the brain. And here we see a slide that's summarizing the distribution of all of the dural sinuses, and the only ones that I think are worth our time is to point out that the superior sagittal sinus runs back like that, drains into what's called the transverse sinus, which continues on as the sigmoid sinus, which then leads into the internal jugular vein. And here we have that cavernous sinus we refer to that drains back through the inferior petrosal sinus, again leading us to the internal jugular vein. Looking at this frontal section, just to show us the cavernous sinus, a very important region because in the lateral wall of the cavernous sinus, we have those nerves that are entering into the orbit through the superior orbital fissure. This is the third nerve. This is the fourth nerve. This is the ophthalmic division of the fifth nerve, and then more centrally positioned in this sinus, we have the sixth nerve. So that, and that are all nerves that are going into the orbit. And three of those four nerves are nerves that are controlling eye movements, muscles that cause eye movements. So the evaluation of eye movements is a very useful thing to do when wanting to evaluate the cavernous sinus, diseases and thrombi and injuries in the cavernous sinus that may affect any of those nerves. An aneurysm of the internal carotid artery can compress that nerve or any of the other nerves. Similarly, on the medial wall of that sinus, we have the pituitary gland. And so expansion of the pituitary gland can affect any of the contents of the cavernous sinus. Thrombi, secondary to infections of the cavernous sinus, can affect any of those nerves.